So good afternoon. I think we're going to start the concurrent session 6A ですよね。6A, Coronary Surgery Video Masterclass 3. CABG in low EF patient. Different surgical strategy tailored around the different heart failure patient. Now, we don't have the first presenter here, so we're going to start with Dr. Stefan Frems. That's the indication for and the benefit of CABG in patient with low ejection fraction.
Yes, thank you very much. Wonderful to be here. I'm very honored to talk at the 10th ICC about CABG in patients with ischemic cardiomyopathy. These are my disclosures. So coronary disease is a common cause of LV systolic dysfunction. In the 2021 American REVAS guidelines, there's a Class 1 recommendation for CABG and multivessel coronary disease in patients with an EF of less than 35% for survival, and 2A for patients with an EF of 35 to 50% for survival. The treatment algorithm for patients with stable ischemic heart disease for survival is depicted here. The algorithm shows that the key features are the presence or absence of left main disease, multivessel disease, and LV dysfunction for ischemic cardiomyopathy. Although CABG received a Class 1 indication in the earlier European REVAS guidelines, in the 2021 ESC heart failure guidelines, CABG no longer received a Class 1 recommendation. However, in the most recent ESC guidelines, CABG once again received a Class 1 indication in patients with multivessel disease for survival. So Salim Youssef is credited with establishing a survival advantage of CABG compared to medical therapy from an IPDMA of very early coronary surgery trials from the 70s and 80s, which compared CABG and medical therapy. A survival advantage was observed for patients with reduced EF, but only 7% of patients had an EF less than 35%. The relative benefit was the same as for patients with a normal EF, but the absolute benefit was greater, given the absolute risk. Caveats are that the patients were young, the mean age was only 51 years, and that medical therapy for ischemic heart disease and heart failure was very limited at that time. In the modern era, the STITCH trial is credited for establishing the basis or reaffirming the basis for CABG in these patients. So the STITCH trial enrolled 1,200 patients, mean age was 59, median EF 28%, and 60% had triple vessel disease. However, the primary outcome of STITCH, all-cause mortality at 5 years, was not significantly different between treatment arms. It is important to note that survival curves initially favored medical therapy and did not cross until 2 years after randomization. However, when the follow-up was extended to 10 years, there was a significant difference in mortality, in CV mortality, and composite outcomes that include both death or CV death. And the differences were increasing with further follow-up. There is one modern trial comparing PCI and medical therapy, Revived BCIS. This was a 700-patient trial. Mean age was now 69 years, EF again 27%, but triple vessel disease was present in only 40% of patients. The primary outcome, death or heart failure readmission, was not different between groups. Also, all-cause mortality was substantial and did not differ between groups. In a separate secondary publication from Revived, the influence of viability was assessed. Viability in this case was typically determined by cardiac MRI. Viability was not a treatment effect modifier, and viability was not associated with outcomes overall. However, the presence of scar was associated with mortality and other outcomes and inversely correlated with changes in EF. I will now present 3 recent population-level studies comparing survival or event-free survival after PCI and CABG. This one shows population data from the province of Ontario, Canada. Overall, there were more patients who underwent PCI than CABG, but the extent of CAD was less. After propensity score matching, CABG had a strong survival advantage over PCI. This is a summary slide from Sweden using Sweetheart registries of patients with EF less than 50%. In adjusted analyses, there was a significant survival advantage with CABG compared to PCI with extended follow-up. In Sweden, CABG in red was the preferred revascularization strategy before 2010, but PCI in blue became the dominant strategy after 2010. On the right, you see the large center-to-center variation in PCI CABG rates. This is a summary slide of patients from the UK who were admitted with heart failure and underwent either PCI or CABG. They did not necessarily have an EF less than 35%. Death or event-free survival was reduced according to instrumental variable analysis, as well as all other adjusted analyses. But similar to the findings in Sweden, there was very large regional variation in the standardized rates of CABG relative to PCI. The most comprehensive review of revascularization in patients with LV dysfunction was this network meta-analysis of observational randomized studies comparing PCI, CABG, and medical therapy. This study was completed prior to Revived. The key message was that CABG was the preferred revascularization strategy for mortality, cardiac death, MI, and repeat revascularization. This is a subsequent study level and pseudo-individual patient meta-analysis limited to contemporary observational and randomized studies published after 2010. There was a survival advantage with CABG compared to PCI according to the study level meta-analysis over the long-term follow-up. A mortality advantage with CABG compared to PCI was also confirmed using reconstructed Kaplan-Meier curves. It's also noteworthy that the mortality was high in the patient population after either mode of revascularization. This is the overall treatment algorithm for the management of patients with ischemic cardiomyopathy from the 2029 AATS expert consensus document. Patients without high-risk features follow this pathway and usually are considered for revascularization. Patients with these high-risk features may require more advanced therapies, and the high-risk features include hemodynamic instability, severe LV or RV dysfunction, or associated severe MR or TR. These are the grafting recommendations from the expert consensus document. Alita LAD received a 2A rather than a Class 1 recommendation, and multi-arterial grafting a 2B recommendation selectively. On-pump CABG and blood cardioplegia received a Class 1 recommendation, while off-pump or beating heart surgery a 2B recommendation selectively. An intra-aortic balloon pump received a Class 1 recommendation for decompensated patients undergoing surgery and is the first choice mechanical support postoperatively in patients with post-cardiotomy shock. More advanced support, either pre or post, received a 2B recommendation. And we'll hear more about microaxial pumps in the next talk. Again, placement of an epicardial lead in patients with LV dysynchrony and left atrial appendectomy and ablation in patients with atrial fibrillation is recommended selectively. The SCAI position considered high-risk PCI according to patient anatomy, comorbidities, and equipment. So patients with ischemic dysfunction are considered complex PCI as they typically have high-risk coronary anatomy, by definition of impaired LV function, and selectively receive mechanical circulatory support. However, not all patients are accepted for surgery. This is a prospective registry of patients in the U.S. who are surgical turndowns. The predicted risk scores are shown here. They're both greater than 5%, and the surgeon's individual predicted risk was greater than 10%. The observed mortality was 5.6%. In other words, similar to the estimated risk and half of what the surgeons estimated. So PCI is a complementary strategy in these patients. Key question is whether mechanical support is routinely necessary for these patients undergoing PCI. There are several trials. PROTECT 4 is one of these trials comparing a microaxial pump with no mechanical support in the other patient group. So to summarize, CABG is preferred. Early risks are only offset over several years. PCI is less invasive and typically associated with less adverse events in the short term. And there's no high-quality evidence comparing the two. I'll now show some key features of a series of studies comparing PCI and CABG in this patient population. This is the study design of STITCH 3C. It's an international multi-center trial of 750 patients comparing PCI and CABG with prognostically important CAD and LV dysfunction. The primary aim is to determine whether CABG compared to PCI is associated with a reduction in MACE or heart failure readmission over a median follow-up of 5 years. Secondary aims are to compare the early risks of both procedures and report patient-recorded outcomes longitudinally. These are the inclusion criteria. Importantly, the institutional heart team says that both patients are amenable to PCI and CABG and that revascularization is appropriate. The main exclusion criteria are listed here. Patients who are decompensated at the time are excluded, as well as patients who may undergo concomitant cardiac surgery, such as mitral valve surgery, are not eligible. There is a collaborative STITCH 3 trials. These have all been funded by their host nation, and so far they are in Canada, Denmark, Sweden, the UK, and France, and the Netherlands recently received support. And the primary objective of this is post-hoc to pool individual patient data to test for mortality. So far, recruitment has started in Canada, Denmark, Sweden, and France. So these are my conclusions. CABG is preferred. PCI is used very commonly. There's no high-quality data comparing the two strategies. A large RCT is necessary to close this evidence gap. And thank you.
We put the question, the comment all together after our presentations. First present,
yeah, we can.
Perfect.
Yeah,
Yes,
you can
yes.
present, Marisa.
So the next presentation is Dr. Marisa Cavasco.
Marisa Sevasco from UPenn and is giving this presentation online. We should have the
Online.
presentation remotely.
Hi, my name is Marisa Savasco. I'm one of the cardiac surgeons at the Hospital of the University of Pennsylvania in Philadelphia. I'm going to talk today about how I use the Impella for on-pump CABG in patients with low EF, and also give some details about how to place the device, how to manage the device intraoperatively, and weaning and removal of the device. I apologize that I can't be there in person today. First, a little background. Literature background. So we all know that there's a benefit to bypass surgery over medical therapy in patients with low EF. The STITCH trial back in 2011 had results from 10 years, and it looked at patients with an LVEF of under 35%, an average EF of around 28%. This was a U.S. National Heart, Lung, Blood Institute multi-center randomized study, and the patients were randomized to either medical therapy alone versus CABG plus medical therapy. And we can see in this bottom curve, this bottom graph, that patients who received CABG plus medical therapy, the blue line, over time they did better. So at 11 years or 10 years out or so, the patients who underwent CABG had a better survival advantage versus the patients with medical therapy. However, within the red circle, you can see that up front there's a higher risk of death from CABG. So overall, the study concluded that bypass surgery yielded a 21% reduction in death versus optimized medical therapy alone. But in the first 2 years of the study, the highest risk of mortality was from CABG. So the surgical risk is weighted up front. How do we mitigate this risk? That's what we're going to talk about today. This is not the only study out there. We see that there's a benefit to CABG over PCI in patients with low EF. This is a great paper from Dr. Guadino and colleagues, Dr. Ruel. This is a retrospective cohort study from a Canadian database for patients with an EF under 35%. It was the largest published study back in 2020 that looked at long-term outcomes of PCI versus CABG in patients with coronary disease and severely reduced EF. and they investigated the risk of all-cause death from cardiovascular disease, MACE, subsequent revascularization, and hospitalization for MI. And they found that those were higher among patients who underwent PCI, and it's a pretty dramatic survival difference, as you can see in the right-hand graph. So the risk of death from cardiovascular disease after PCI versus CABG was also noted to be significantly higher in the subgroup with diabetes, again, reinforcing what we know as surgeons, that bypass surgery really does have a great benefit for our patients with low EF, and then particularly in the subgroup with diabetes. A great paper from Veli Topkara and colleagues at Columbia. This looked at the New York State database of over 55,000 patients who were stratified into 4 different categories of LV function who underwent CABG. And notably, this study was important because it included around 10% of patients who underwent off-pump CABG. And right now in the United States, that's around a similar percentage of patients who undergo off-pump CABG today. It might be a little bit like 13-15%, but still around the same ballpark. And it showed that in patients with low EF of under 20%, these patients had the highest in-hospital mortality and the early both in-hospital and early mortality, which was around 4 times higher than those of relatively normal EF patients, which is seen here on this bar chart. So further data showing that these patients are getting bypass surgery, but they have a higher risk of upfront mortality. STS database looked at bypass surgery in the United States. Dave Shahian and colleagues. There were over 750,000 bypass surgery patients within this study, around 2 years of CABG data in the United States. Around 10% of bypass surgery patients had an EF of less than 35. Strikes me as a little bit low. I would have expected a little bit more than that. But nonetheless, in this study, patients with an EF of 25 to 34% had around a 5% risk of mortality. And those with an EF of under 25% have a 7% rate of mortality. So in total, those 10% of patients represented a disproportionate risk of mortality. And in this study, around 4,000 people who may not necessarily have had to die if we had better ways of managing them post-operatively. So as I mentioned, so we see that bypass surgery is being performed for high-risk patients, i.e. those with low EF. And why is this being done? Well, we're being asked to do it because we know that there are better long-term outcomes overall than medical therapy or with PCI. Yet, there's a higher upfront mortality in these patients. And so what are our options? What can we do about it? Currently, our options for post-cardiotomy shock. So we all come out, inotropes and pressors, but they're not enough. And we know that the higher the vasoactive inotrope score is, the higher the postoperative mortality risk. What we don't want to do is we don't want to end up on rocket fuel. And this has been shown numerous times in the literature. The higher the vasoactive inotrope score, the higher the risk of mortality. Why is that? Well, inotropes, they're a necessary evil in some ways. They increase myocardial oxygen demand. They increase the risk of arrhythmias. The high doses can delay extubation. So what are some of our other options? Balloon pump. No clinical trial has ever shown a benefit in a shock patient. ECMO, same thing. No clinical trial has shown much of a benefit. There's hemocompatibility issues. You insert it through the groin or centrally. Either way, there's bleeding and clotting and thrombotic complications. So not ideal. Can't get the patient out of bed. Can't ambulate the patient. And then what else? Tandem heart. It can be relatively harder to insert. It requires a transeptal puncture. Again, limited benefit. And so here we have the Impella device, which is, I see it as a new paradigm in postoperative support. But before we get into that, let's just reiterate. So who is at risk for coming out on high-dose inotropes, and who could benefit from support with a temporary MCS device? So this is intuitive. Patients with low EF. So we know that these patients have a higher risk of postoperative mortality and post-cardiotomy cardiogenic shock. Patients who are needing an urgent or emergent bypass surgery. So again, we don't try and do too many emergency CABGs, but urgent meaning those patients who come in with an end stemming, they can't leave the hospital. They might have come in a little decompensated heart failure. So patients who are sick. If they have a low index going into the surgery. if they come in with some end organ dysfunction, and certainly anyone coming in shock. Diabetes puts you at a higher risk for needing support if your coronary targets aren't great, and then other typical surgical risk factors, prior history of radiation, RV dysfunction, if there's another valve that you need to address. So what do we need to think about when we think about low EF CABG? We all do this. We might not have it elucidated, but I tried to elucidate it here. So what do we think about? We think about the targets. That's probably what I look at first. Well, you called me for a CABG. Does the patient even have targets? Are they diffusely diseased small vessels versus nice targets? It might sway me one way or the other. How does the patient present? Are they coming in with angina, or do they have heart failure symptoms? Have they had multiple prior heart failure admissions? Is this something that's necessarily going to get better, or this kind of end-stage cardiomyopathy that needs to be referred to advanced therapies? Do we have a baseline right heart cath? If the patient has an ICD in place, that means they've been in the system, they've been seen for low EF before. Is there a secondary cardiomyopathy that we're missing? Do they have LV dysfunction out of proportion to their coronary disease? How dilated is the LV? Is this a normal-sized LV, or is this an 8-centimeter LV? Is there concomitant mitral valve dysfunction that may or may not need to be addressed? Now, use of viability studies, I think we could all talk about this for quite a while. PET CT versus MRI. This is going to be a little bit outside the scope of the talk today, but STITCH trial, one of the subgroup analyses in the initial report showed that myocardial viability was not necessarily associated with the survival benefit, but conversely, there was no increased mortality in the absence of viability. Finally, do these patients, should they just be shuttled towards advanced therapies? Are they a candidate for transplant? Are they a candidate for VAD? But however, if we do have a viability study, and in the setting of significant viability but low EF, should we try CABG? So these are questions I think we're all thinking about and we're all working through, and hopefully we'll come to more of a consensus going forward. But I did want to illustrate this today I have two cases. The first one is a little bit more straightforward. It's a 72-year-old man with severe triple vessel disease and an EF of 10% and moderate MR. He came into the ER with 1 month history of shortness of breath, chest tightness, cough, and palpitations. He was tachycardic to the 120s. He had jugular venous distension, decreased breath sounds, and his legs were swollen. He had a positive troponin, and I'll show you he had some end organ dysfunction on his labs. He was having some VT, his chest x-ray looked wet, a point of care echo showed severely diminished EF. His past medical history is notable for an inferior MI. He had a drug-eluting stent to the RCA over 2 decades ago. His last known EF was normal. He also had your typical culprits, hypertension, hyperlipidemia, and diabetes. He was admitted, and he went straight to the lab. But here you could see his x-ray. You could see his BNP was severely elevated. He had a positive troponin. His creatinine was elevated, and he had some transaminitis. And you could see what his EKG looks like. Here's his point of care echo. So you can see the LV is not doing too much. Base moves. Here's a contrast view. RV looks a little bit full as well. Here's his left heart cath, however. Really nice targets. You can see there's a tight prox RCA lesion. They called it 50% left main. He has a 70% prox LAD lesion as well. He also has some circumflex OM disease. But overall, nice surgical targets, as we would say, a target-rich environment. Here's his right heart cath. So RA is 15, his wedge is 25, his PA stats 54, his index 1.6, and his SVR is 2,500. So he's a little bit volume overloaded and his index is marginal. However, he hasn't received any medical therapy yet. Hasn't received any Lasix at this point, and he didn't get an inotrope exposure. So there's modifiable factors on this, or modifiable things to do for his right heart cath with medicine alone. You can see his STS score is around 9% for an isolated CABG. So this patient had several risk factors for low cardiac output post-operatively. His EF was under 20. He needed an urgent operation. His age is older than 70. he had left main and triple vessel disease, and he had some electrical instability. And in the words of one of our attending interventional cardiologists, he is at risk for recurrent ischemia, MI, and death. And I discussed with the patient and his daughter that with his severe elderly dysfunction, his in-hospital mortality risk is significant, and surgery will be at higher than usual risk, and we'll have to evaluate his candidacy. So that really sums it up. But given his age, he was too old to qualify for a heart transplant. We hadn't met him yet. There was some drinking history, so it wasn't a pristine transplant candidate. His ventricle wasn't really that dilated out, and he had some really nice targets, and potentially we see a way of getting him through this with revascularization alone. So just to give you a picture, this is what his echo looked like. We did take him to the operating room. His EF around 10, ventricle maybe is a little bit dilated. He has some mild to moderate MR. Always looks worse on the TEE under anesthesia than on the pre-op transthoracic. But first, we optimized him, right? We tried a single low-dose inotrope and diuresis, and that improved his swan number significantly. Now, if it didn't, you could make an argument for putting an Impella in preoperatively. However, he responded to a low-dose inotrope and diuresis. And after 5 days of optimization, I took him to the operating room. I placed a right axillary graft. I prefer to do Impellas via the ax. However, I have done them direct as well. We use the Impella a lot for shock patients, for bridging patients to heart transplant. And we have a very efficient way of going in via the ax. But it really is a surgeon preference. I use fluoro. I do all of the wire work before I even open the chest. They can be taking vein. And then I get the 018 wire into the ventricle. Then I proceed with the bypass surgery. In this case, we did a CABG 5. Prior to coming off, after filling the ventricle, I placed the Impella using the 018 wire that I had placed before. We just use TE guidance to put the Impella in. And when the heart is full and we're starting to wean from bypass, this is the time that I do it. Once it's positioned well, we turn it on, and then we complete the case. I fully reverse with protamine, and we have some bicarbonate in the purge. In terms of this patient's postoperative course, he was extubated post-op day 0. Once his chest tubes looked good, which they did in the beginning, so no problems, we started systemic bivalverutin with the PTT goal of 40 to 50 at hour 6. We weaned off his dobutamine and his levofed by post-op day 2. We diuresed him. He was walking around with the 5.5. Now, once his hemos looked good, I took him back to the OR to remove the 5.5 under local, and that was on postoperative day 4. We did get a transthoracic echo post-removal, and it showed his EF was 25, but that was on 2.5 of dobutamine. Eventually, he went to the step-down unit, and he went home on postoperative day 14 on a little bit of GDMT. Now, here you could see his echo prior to discharge, 30 to 35%. So already starting to see improvement. And then his most recent echo, his EF was around 40%. So overall, we had a nice result. And he had an EF around 40% with really no residual MR. Just a quick couple notes on axillary insertion. I look at a chest CT. You look at the arch. Make sure there's no aberrant subclavian. Make sure there's no heavy calcification. I always go in the deltopectoral groove. I find the anatomy to be most consistent and the placement to be easiest. I spread the pec major and I divide the pec minor, and I gently move the nerve out of the way if it's in the field. I get an ACT at 250. Graft sizes 8, 9, or 10 have worked for me. I use blue vessel loops to get around the artery, and I bevel the graft to 60 degrees. So the smaller the vessel, the bigger the bevel. And the vessel I found is never too small. I mean, they're always generally elastic and can accommodate a 5.5. The vessel can be calcified, however, and that could lead to a difficult placement. And I would say that's the one of the indications to kind of not go axillary, and you might want to try direct. I sew it with a single running 5.0. I use bioglue on the anastomosis. And then I generally cross the valve with an 035 and a 5 French pigtail. Sometimes I need a glide wire. Sometimes I use a JR4 at MPA if the pig is not good enough to cross the valve. Intraoperatively, I do all the graft and wire work prior to starting the chest portion of the case. Again, you could simply just place a direct impella. I put the 018 wire into the ventricle and then I proceed with the case as normally as I would. And in the next case that you'll see here, I'll just try and get to it very briefly. If you're doing aortic valve work after the aortotomy, pull the 018 wire out of the ventricle. It remains in the ascending through the cross clamp, of course. Do your aortic valve and then replace the 018 wire through the new aortic valve. After the cross clamp is off, and again after the ventricle is filled and when weaning bypass, put the 5.5 on the 018 wire and pass it into the ventricle. Turn the device on at a low P level and adjust as the hemos allow. In terms of weaning and removal, generally I have the patient extubated and they're on a single low-dose inotrope and off pressors. They have intact end organ function, and I start to turn down the P level as hemodynamics allow. I do a brief trial at P1. If the hemos are good, I take it out either that day or the next day. I don't use an echo. I don't think the echo will necessarily show an improvement. It might not be any different from pre-op, but as long as the hemos are good and the patient is stable on a single low-dose inotrope, maybe a little bit of pressor, there's normal end organ function, then I think it's okay to remove the device. In the OR, I take my patients back to the OR and I just use some MAC and local. I reopen the incision. I leave one of my vessel loops, the distal vessel loop, in, and this helps prevent arm embolism during removal. Some people prefer just putting a blood pressure cuff on. It's, again, surgeon preference. But if I leave my vessel loop in, the distal one, I pull it up, and I do this to prevent anything from going down the arm. I put the patient head down, I give some gentle carotid pressure by the anesthesia team, and I take the device out. The patient tolerates that very well. I did just want to run through a second case to provide kind of a counterpoint. Even if you don't see a really dramatic benefit in EF, as we did with the prior case, you can get sick patients through cases with the device. And this is a patient, he's a 63-year-old who had an NSTEMI at an outside hospital and was transferred to us for consideration of CABG versus advanced therapies. He, like I said, rolled in for an NSTEMI. His baseline EF was 30, and now it was around 10. On transfer, he looked fine. He was normotensive. He was in sinus. He had no edema. He looked compensated. On his outside hospital labs, he had an elevated troponin, and his BNP was 2,000, so not too high, but high, and his creatinine was 3.2. Notably, he had a prior AVR for endocarditis in 2013. He had renal cell, and he had a cryoablation in 2023 with a baseline creatinine of around 3. Very nice guy, worked at a car dealership, married with children, had been feeling good. So this is his echo. You could see his ventricle. Neither ventricle really looks too hot, but his EF is around 10%, maybe 15. There's his long axis view, so just another view. Ventricle is not doing that well, and his short axis view. And then here's his left heart cath. These are images obtained from the outside hospital, and you can see he has targets. You know, there's something on the right. His LAD is diffusely diseased. He's a very tight prox LAD stenosis. You can't really see it on this view. I'll show it to you on a second view. But he had his lateral wall targets were really the best. But again, these aren't as robust of targets as we saw in the prior case. And then here are his right heart cath, and we had a PET CT study. So his RA, he was pretty volume optimized. His RA was 9, but his wedge was 24, and his index was 2.2, but his PA sat was 48. So imperfect, but overall he was mostly compensated and but sick. Now I hadn't heard about him. Then the cardiologist got a PET CT, and it showed he had significant residual myocardial viability in all of his territories. And so here we go. So we have this patient. Should he undergo CABG, or should he stay with medical management? He has pan viability on a PET CT. His targets are perfect, or not perfect, but they're acceptable. He had a baseline low EF of 30, but now it's 10. And when he came in, he had both angina and some heart failure. So what else could we do with him? What about advanced therapies? Well, he's not a candidate for transplant because he had recent renal cell. And for LVAD, his ventricle was actually not that dilated. His creatinine was around 3. He's a possible candidate for an LVAD, but there's a high risk of renal dysfunction. And he wasn't really interested in a VAD. Plus, I have 3 heart failure cardiologists asking me for revascularization. The interventional team said there's not great options for PCI. And then moreover, there's concern for low flow, low gradient AS. This was ultimately verified by an intra-op TE. So you can see here, this is what his echo looked like. So we did end up taking him to the operating room, did a re-op sternotomy. We had to address the valve. We did a triple bypass. And like I mentioned in a previous slide, we placed the 018, I cut down on the right axe first, and I placed the 018 wire into the ventricle through the old bioprosthetic valve before I did the re-op sternotomy. And then after I put the cross clamp on and we opened the aorta for the valve, we just simply took the 018 wire back out through the ventricle, back out through the aortic valve. We excised obviously the old valve, put a new valve in, placed the 018 wire through the new valve, and then took the clamp off after we were done with the surgery and slowly weaned from bypass with the aid of the Impella. Post-operatively, he did fine. He was extubated post-op day 0. I weaned the Impella. We diuresed him. He went back to the OR on post-op day 3 because his hemos were fine. And I left him on a little bit of dobutamine. He went to the step-down unit. And you could see on the short axis view, his ventricle looks a little bit better. Gradually, he got a CRTD. He weaned off milrinone. He went home on post-op day 16. He did have one readmission, and this is a recent case on October 30th for inpatient optimization of GDMT. But you can see we didn't have like a very robust response in terms of his ventricular function. But what did we learn? This is a high-risk CABG valve case. He had heart failure symptoms on admission. His targets were diffusely diseased. He was a re-op. He needed a valve, and he had a baseline creatinine of around 2.5 to 3. So he's high risk, but I have multiple cardiologists requesting revascularization. So how do we get through the patient? How do we get the patient through the case safely? The EF didn't improve as dramatically as the first case, but we didn't have any end organ dysfunction. He was extubated on post-op day 0, and he eventually was able to go home because we could walk him around. I avoided ECMO. So we can discuss whether there was a better option for this patient, if he should have went TABG and high-risk PCI, etc. But sometimes we find ourselves in situations where we're being asked to operate on some pretty sick patients, and this device is a way for us to get these patients through. So I think there's a paradigm shift. We can use the Impella as a safe, preemptive, elective device. We can get patients to potentially heart recovery instead of heart replacement with a VAD or a transplant. And I'm speaking as a transplant VAD surgeon. These patients that we know they're a higher risk for mortality, but early elective placement helps, right? It allows early extubation. We avoid the inotropes. We avoid the high-dose pressors. We avoid rocket fuel, quote unquote. We have less risk of CVVH. There's really minimal hemocompatibility issues. Our physical therapists like it better. The device is easy to remove. You can do it with local at the bedside. I just prefer in the OR awake. There's very minimal complication profile. It's certainly easier for the nurses to care for these patients than ECMO patients. And then we do have public reporting. And so finally, out with the old and in with the new. So the old way of thinking was mechanical support had a high rate of mortality, it's futile, it's complicated, and has a high risk of complications. It's hard to place, hard to manage, and specialized knowledge is needed. But the new way of thinking is Impella as an LV unloading device decreases myocardial oxygen demand, it promotes recovery. You can use it preemptively, it has a good safety profile. And overall, I think it's a set it and forget it, and then it's easy to wean. Thank you very much. I apologize for running over, and I apologize for not being there in person. Have a great day.
Okay, so we'll go on to the next talk. Mark Lenov will give a talk. Had in Cleveland Clinic, and he's going to talk about something he knows quite a bit about, mitral valve surgery, but this is for someone with a poor EF.
Thanks a lot. I think it was hard for the organizers to find a spot for me on this program, but they found one. The mitral valve in patients with low EF, I really only have one message. I've got like 30 slides, but I have one message. And the one message is, if someone's got severe ischemic MR, replace the valve. Don't ignore it. Don't repair it. Replace it. Thank you very much. Are we back on time? All right, well, I may as well support it with a little bit of data. MR comes in two basic classes. You've got your primary MR, which is fun to fix. It's prolapse. The valve makes the ventricle sick. You fix the valve. It's easy. It's fun. Not so easy and a lot less fun is secondary or functional MR, where the problem isn't the valve. The valve now is bad, but the ventricle, or sometimes the atrium, makes the valve sick. And then you've got a problem, because the heart is not going to get fixed completely by fixing the valve, but you need to look at them both. And I'm just going to focus on the one in blue, ischemic MR at the time of CABG. These are now the current classes of functional MR. But still for us, the most common is ischemic MR at the time of CABG. And I'm going to talk about severe ischemic MR. You just saw a great case where there was mild to moderate MR. She left it alone, and it did not get worse. It even got better. And that's the right answer for mild to moderate MR. Don't go after mild to moderate ischemic MR. Do go after severe ischemic MR and replace the valve. In severe ischemic MR, we all know what happens. The ventricle dilates, the ventricle is dysfunctional, the papillary muscles are connected to the cords, papillary muscles get splayed out, the valve gets restricted, and it leaks. So here is a typical case, severe ischemic MR in a patient who's had a previous CABG, a 72-year-old guy. He had a CABG years ago, then he had an AVR after that, and now he comes in with heart failure. And the first thing you want to think about, based on the COAP study, is, hey, maybe they can clip this valve. Maybe he can get a TEER, a MitraClip, or a Pascal device. Well, of course, his native coronaries are just horrible, but we've been hearing over and over and over in this conference, this is why CABG is great. This is what makes people live longer. This is why my dad is 91 years old after having a CABG at age 44 by Dr. Loop at the Cleveland Clinic. That's almost 5 decades of durability. This is not my dad's cath. He wouldn't let me show it. So this is a different guy, and he's got that Lima to LAD. And he's got bad function, and he's got a lot of MR, and it's causing him symptoms. He's on GDMT, but he's still symptomatic. So he's referred for surgery, and the question is, what are you going to do? He doesn't need a repeat CABG. His mitral valve is not going to kill him, but he says, I cannot go on like this. Well, in the past, many of my friends and colleagues would say, see MR, fix MR. Picture a tall, very gregarious surgeon from the University of Michigan named Steve Bowling. And he's a great speaker, and he's an outstanding surgeon. And he told us all, just repair it. How hard could it be? Put an annuloplasty in. I'm like the only mitral valve surgeon in the world who does not have an annuloplasty named after me. But that's not why I say don't use an annuloplasty. There are these annuloplasties. There are some really strange-looking angioplasties. Some are off the market now. And some have contended that, hey, you have severe ischemic MR at the time of CABG, it's a cure. Well, I don't really think so. This is a compendium of studies looking at people with severe ischemic MR who got an angioplasty, and the curve is the return of moderate or greater MR over time. And all of these studies show the same thing. Angioplasty is not a cure for severe ischemic MR. It's not a cure. And sometimes it even causes mitral stenosis. You take a 100-kilo guy, put in a 26-millimeter angioplasty, that may not leak, but that's about this big. That's going to cause stenosis. So should you repair or replace? I already gave you the answer. I should have quit while I was ahead. Replace. But why do we say replace? Because the data from this study, from the CTSN, supports it. And this study is the only good randomized controlled trial in this space of severe ischemic MR. Patients were randomized to a repair with an undersized ring or to a replacement, and usually you want to use a bioprosthesis. These are older people with bad hearts. Bioprosthetic durability is going to get them to the finish line. So this study had about 250 patients, and the primary endpoint was a surrogate, but it turned out that we got better data than just this point. The primary endpoint was indexed LV end-systolic volume, and we needed that because we couldn't do a study powered for survival. But we got some really meaningful clinical data that I'll show you. These were older people, 70-some years old. Almost all of them had a previous MI, many had prior CABG, prior PCI, and heart failure, not angina. Heart failure was the predominant symptom. Just like the patient I presented, he's not coming in with angina, he's coming in with shortness of breath, pedal edema, he's fatigued, he can't do anything. And overall, the EFs were not horrible in the people in the study, around 40%. Almost all of them had concomitant CABG. And very rarely a subvalvular procedure was used. And I will say that the subvalvular approaches to severe ischemic MR may or may not work in some people. The data there is not compelling. If you've got something that works, or you think it works, study it, write about it, and send me your slides so I can include them. But until then, I would not do many of these. And it took a little longer, just a few minutes, to fix the valves. So again, the primary endpoint was a volume endpoint, but we had some good clinical data. First, though, for the primary endpoint, patients having repair in blue, replacement in red, this shows the LV end-systolic volume at 2 years, no difference. The ventricles did not shrink any more or any less with repair versus replacement. So repair, replacement, no difference on this. Mortality, again, repair in blue, replacement in red, no difference. MACE, same thing, no difference. But MR recurrence after mitral valve repair, 2+ or more, big difference. The valves start leaking again. You come out of the operating room and you feel like you're a combination of Tyrone David and Denton Cooley and Michael DeBakey because the echo looks gorgeous. It does not stay that way. These valves with a small angioplasty look good in the OR, and they look bad in the ensuing months. And when the valves start leaking again, the patients get more heart failure. The blue are the ones who had a repair. And they get more hospitalizations. So if you look at 2 years, cumulative failure after repair versus replacement, repair, about 65% of them either died, got recurrent MR, needed recurrent intervention. So ischemic MR, trying to repair it when it's severe, doesn't work. There's no difference in survival between repair and replacement, but repair patients get more recurrent MR, replacement is more durable. Well, this study, while published in the New England Journal of Medicine, was criticized. People said, are you really sure that the durability is that bad and that the clinical outcomes with repair are worse? The answer is yes, we are sure. This is your choice. You're doing a CABG, they've got severe ischemic MR, replace the valve. So in this patient, He got a very nice bioprosthesis that is never going to leak again. I'm never going to get a call saying, remember that patient? I'm not calling to tell you he's doing great. I'm calling to tell you his valve's leaking again. This valve will never leak again. Well, one criticism of the trial was maybe these were just bad surgeons. They didn't know what they were doing. They did the operations wrong. If they knew how to repair the valves would have worked. Well, some of these surgeons are in this room right now. These are all really, really good surgeons. These are people who knew what they were doing. Others have said, well, if you look at the data and parse it, which, by the way, you're not allowed to do all these subgroup analyses, but let's say you were allowed to do it. The people who got a repair that lasted actually did do better. The people with no recurrence, this is the ventricular size, if they got no recurrent MR, their ventricles got smaller, and overall they were clinically better. So I've been told a good repair is a good thing. I'm not going to disagree with that, but the problem is, can you predict a successful repair with severe ischemic MR? Can you somehow look and say, this is the one where my repair is going to last longer than 6 months? And the answer is, you cannot reliably predict a successful repair, and therefore, severe ischemic MR, replace the valve. I ended where I started. Thank you.
Thank you. Very convincing.
Are you all going to replace?
Yes.
I got some hands. Good.
All right. Maybe some discussion, but we're going to go to the final presentation by Dr. Min Sook Kim. Is he around?
Yes, it's coming.
Good afternoon. Good evening. I thank the Society for giving me the opportunity for the presentation. I have nothing to disclose. And transthoracic echocardiography is useful because it can be performed non-invasively and quickly, as we all know, and is most commonly used imaging modality before and after CABG. It contributes to the diagnosis by detecting LV wall motion abnormalities, and it helps in assessing the myocardial viability to define potential efficacy of revascularization. For the echocardiographic assessment of regional LV function, the LV segment is divided into segments, and the segmentation reflects coronary perfusion territories, resulting in 16, 17, or 18 segment model. A wall motion score can be assigned to each segment, and a 4-grade scoring is generally recommended, but 6-grade scoring system could also be used. The akinetic myocardium in transthoracic echocardiography is known to represent stunned, hibernating, or non-viable infarcted myocardium. The myocardium would be reversible after revascularization if the myocardium is stunned or hibernating. However, it would be irreversible if the myocardium is infarcted. The presence of myocardial thinning is known to be a marker of chronic myocardial infarction, and since it represents the myocardial infarction, the end-diastolic LV wall thickness was demonstrated to be a marker of myocardial viability and hence could predict the recovery of function. So, akinetic myocardial segment is defined as no systolic myocardial thickening, and it may represent stunned, hibernating, or non-viable infarcted muscle. And in contrast to hypokinesia, which is reversible in most instances, akinesia is not completely reversible after revascularization. More than 40 years ago, there was an interesting study which examined the correlation of echocardiography with post-mortem histopathology. While 100% of the pathologically transmurally infarcted segments were akinetic or dyskinetic, 10.8% of the akinetic or dyskinetic regions were histologically normal, and 18.5% of the akinetic or dyskinetic regions were only subendocardially infarcted zones. So, the authors have concluded that hypokinesia was nonspecific, which can be seen in subendocardial infarction or normal myocardium. And akinesia or dyskinesia usually signifies, but is not entirely predictive of, transmural infarction. Since the akinesia usually signifies transmural infarction, it is understandable that the regional akinesia was analyzed to be a strong predictor of mortality in patients with suspected MI in this previous study. So the question is, will a kinetic myocardial segment improve in function after revascularization? In a previous study, which included 121 hypokinetic segments and 13 akinetic segments from 50 patients, there was an improvement in wall motion scores of hypokinetic segments, but there were no changes in the akinetic or dyskinetic segments during the post-op 3 months after CABG. On the contrary, in another study which included 69 hypokinetic and 32 akinetic segments from 42 patients, showed improvement of segmental wall motion in 35 hypokinetic and 19 akinetic segments, and there was no significant difference between the two groups. However, these previous studies had no mention on the graft patency, and since the graft patency is crucial in evaluating the efficacy of the revascularization, we wanted to find out, will a kinetic myocardial segment improve in function after revascularization if the grafts are patent? In a previous study, which included serial comparison of the graft patency rates early postoperatively 1 year and 5 years after CABG, saphenous vein graft showed a significantly decreased patency rate during the first postoperative year, and ITA patency rates also decreased significantly during the follow-up period. Since complete revascularization itself does not guarantee the graft patency and benefits of CABG, we examined the changes in echocardiographic parameters in only CABG patients with proven graft patency on follow-up coronary angiogram. So this is one of our latest study. A total of 1,616 segments from 101 patients who had all patent grafts at 1-year angiography were included in the study and have revealed that the LV ejection fraction improved over time, and the improvement was higher in the patient group with LVEF 35% or less. And the wall motion tend to improve over time, and the improvement was significantly higher in the segment group with akinesia, and the improvement was not significantly different between akinetic segment group with thinning and without thinning, and no significant difference in changes were analyzed among coronary artery territories. So the conclusion of the study was that the LV ejection fraction and regional wall motion improved during the post-op 12 months after patent revascularization, regardless of the presence of akinetic segments. So the complete revascularization, including akinetic myocardium, should be considered because stunned or hibernating myocardium, which would benefit from the revascularization, might also be included in the akinetic segments. This is one of the examples of the patient that is included in the study. It was a 72-year-old male who underwent off-pump CABG, and we used saphenous vein graft as a Y composite graft based on inside to left ITA, and left LITA was anastomosed to LAD, and vein graft was anastomosed to first diagonal and first OM and distal OM sequentially. And the patient's preoperative echocardiographic findings are shown in this video. And it was, I'm not sure it's big enough, but the segments were analyzed to be hypokinetic to akinetic. And his 1-year follow-up coronary angiograms revealed patent CABG grafts. And the post-op 1-year echocardiographic findings were analyzed to be mostly normal. And this is another example. He was a 61-year-old male. He underwent also off-pump CABG, and used a vein graft, anastomosis as Y composite graft based on left ITA and LITA to LAD, vein graft to first diagonal, first OM, and PL branch sequentially. And his preoperative echocardiographic findings were analyzed to be, again, hypokinetic to akinetic. And his post-op 1-year angiograms revealed the patent grafts. And again, post-op 1-year echocardiographic findings were analyzed to be almost normal. Similar to this echocardiographic study, we have performed another study which focused on the myocardial SPECT in order to find out if the segment with persistent or irreversible perfusion defect in myocardial SPECT also improve after revascularization. By analyzing the changes in stress and rest perfusion in myocardial SPECT segments in patients having all patent grafts at 1 year postoperatively, we have concluded that the stress and rest perfusion in myocardial segments with persistent perfusion defect also improves over time, and also complete revascularization, including myocardium with persistent perfusion defect on preoperative SPECT, should be considered when performing CABG. So these are the take-home messages. Akinetic myocardial segments in preoperative echocardiography represent stunned hibernating or non-viable myocardium, and some portion of the akinetic myocardium will still contain stunned or hibernating myocardium, which would still improve in function after patent revascularization. So complete revascularization, including akinetic myocardium, should be considered when performing CABG. Thank you for your attention.
That's beautiful data. I think we finished the ordinary time, but we don't have a next session. Would you go for just short summarizing
Absolutely.
comment?
No. Comments and interaction, please. We love that. Yeah. If you have any question, feel free to, please.
And identify yourself.
Yeah.
Rosati Fabrizio, Brescia, Italy. So my question is, I want to be a little bit provocative. We saw 5 bypasses in patients with a low ejection fraction before. I think in that case, personally, it was like over-treat the patient. It was a very, very sick patient, very, very sick heart. My question is, why we don't think to hybrid procedure? Once the LAD revascularized, maybe we can take, it was not a diabetic patient, one stent to the OM and one stent to the RCA. I think the patient went fine, but it was a very, very risky procedure, I think.
You want to give a... No. Please.
I think that depends a lot on the graftability of the patient. Certainly, if the targets are poor, that's something that may be better suited. But I think in someone with good targets, that's a better strategy. The other thing is that they have to be on, there's the bleeding problems afterwards, and there's the patient would have to be on DAPT. In general, that's someone I think that's better suited with more preserved LV function. Now, you do a lot of hybrid, so maybe...
I do, and I love hybrid, but I must admit that even in my practice, if you come with low ejection fraction, very low ejection fraction, my tendency is to try to do complete revascularization. And you have heard me before, I think multi-arterial is almost better than the complete revascularization. The concept of complete revascularization is changing with complete medical therapy, with guideline-directed medical therapy, with arterial conduit. But for low ejection fraction patients, I still go for a sternotomy, full revascularization. If anything, an Impella that I've been using too in selected cases, and I found myself in a good spot. And I think a good protection of your myocardium, be fast, be clean, no bleed, and a little bit of a surgical sterile holy water for those cases.
I think the other situation is maybe a reverse hybrid. If someone comes in with STEMI, has primary PCI, has very poor PCI options, then do bypass for complete revascularization.
And also an age, like if you are in the 80s, I might consider you. But if you are like a 50, 60, like we've seen, and I think I will try still to give you the best revascularization I can and just hope for the best. Dr. Pascas.
I particularly enjoyed, all the speakers were great in this session. It was tremendous. I have a question for Dr. Kim. Young Dr. Kim, there we are. You pointed out that patients who had patent grafts to akinetic segments, those segments recovered and contributed to an improved ejection fraction. And the implication was, gee whiz, we should be doing a better job and make sure that all of our grafts are patent, because if we do so, these akinetic segments will wake up and live. And I'm just going to throw a slightly different interpretation of that out there. Suppose, in fact, outflow depends to a degree on viability, and that you and your group in Seoul did a perfect job of every one of those grafts. But the patency to those akinetic segments actually depended upon the outflow in those segments. And the akinetic segments that had more viable muscle before you met the patient had better likelihood of a patent graft and subsequent recovery of function. I'm just not sure which is the chicken and which is the egg.
Yeah.
For sure, closed grafts don't help anybody or any segment of the heart, but I'm not sure those segments failed to improve because the graft closed. Maybe the opposite is true. The graft closed because those segments were truly dead.
Yeah, I totally agree with your point. We also had, in the study, we had about like 4 or 5% of the patient had at least one occluded graft.
Yeah.
And I personally also believe that those patients has occluded graft because the distal bed of the native coronary arteries wasn't that good.
Yeah.
I think. Thank you.
I've noticed that not every graft to a CTO vessel has a great TTFM.
Very true.
Yeah.
The flow is not, sometimes the flow is like, wow, it's 150 cc's. I've had a great day. This patient's going to live forever. But sometimes it's 22 cc's.
Yeah.
And you're wondering, what the heck? And I think it's because that tissue's dead and it doesn't have a vasoactivity to react and accept the new flow that you're offering. And again, I'm doing these off pumps, so I can measure the flow immediately.
Dr. Pascal says, on the microphone, do you do MRI, patients with 30% EF, do you do an MRI to assess viability in your practice right now or no?
If the patient has angina, they can benefit from coronary revascularization. I only do MRI if I'm trying to find a reason not to operate.
Interesting. Thank you. I knew the answer. So. Please.
Hi, Hassan Nami from Detroit, Michigan. My question is for Dr. Gillenhoff. And I don't mean to kind of beat the issue more, but since I saw the CTS-NET study for ischemic MR, I always wonder about the subset of patients who had a sustainable repair improved, and they did much better than anybody else. I wonder if the sustainable repair was just because that subset of patients had viable myocardium and improved with the bypass surgery, and that's why they responded more favorably to repairing the MR. I wonder if there is a role for an MRI or high-quality viability study to decipher or can distinguish that subset of patients and serve them better than a bioprosthetic valve.
Great idea, great point. We did not have viability studies in that study. And I think that's hypothesis generating, worth testing. With no viability studies, only about 25% of the people who got a repair had a good repair and benefited, whereas 3/4 of the people who had a repair did not benefit. But maybe you're right, and I think that's worth studying.
Please.
Dario Kandura from Leiden, the Netherlands. I enjoyed all the presentations, but particularly the one from Dr. Kirinov, because I come from a center since Professor Dion was the chief there, where heart failure and mitral valve repair is a must. And if I could believe everything that you said, believe me, my life there as a junior surgeon will be much easier. But also the paper that you showed taught us that there are patients that sometimes we see recurrent MI, but we see particularly in patients that have dilated preoperative left ventricle, more than 65 millimeter, and patients that leave the operating room with a contention length that is less than 1 centimeter. So with good downsizing, usually our patients leave the operating room with a mean 26. We don't see much recurrence. So I would like to believe you and then go home with this take-home message. But if Professor Klaus was here, probably he wouldn't completely agree with you.
I think it's good to keep your job. So don't take my message. Take your message, which is the same as Dr. Nemi's message, which is that there are certain people who do get a successful, sustainable repair. And maybe if we all put our heads together, we can come up with a study to figure out who they are, because I gave a one-size-fits-all approach, just replace it. And usually that belies some ignorance.
Yeah.
If we're doing one-size-fits-all, that means that we don't know enough yet, but we should learn.
Dr. Gilinov, just because you're a mitral valve replacement, prosthesis, does that matter? Do you have a prosthesis of choice? Pericardial, bovine, opening pressure, low opening pressure, supraannular, or is there something you like or not really?
For
Mitral valve replacement in ischemia?
No, for implantation, chordal preserving, and then we use more porcine valves in the mitral position than bovine, but if you look at the studies, you can find both ways. So I think any bioprosthetic valve is going to be good. The nice thing about the porcine valves and the newer bovine valves is the struts are short. So if you do get a strut a bit misplaced toward the LV outflow tract, it's hemodynamically insignificant.
Thank you.
Additionally, Dr. Gilinov, I think it's preserving subvalvular tissue, a whole mitral valve intact, or take out just anterior leaflet. I think a lot of different ways doing that. Do you think that makes any difference? I'm not certain there is currently data available or not, but from your practice, what do you think?
The question is, if you're replacing the valve, should you preserve some leaflet, all the leaflet, or none of the leaflet? And definitely preserve the posterior leaflet if you can.
Yeah.
Sometimes in a rheumatic patient, you can't because there's no space. But in people with a bad heart, preserve the posterior leaflet for sure, and that gets you about 90% of the preservation of LV function. If you preserve the anterior leaflet, you get a little bit more, but it's technically a bit more challenging because you either have to debulk it or split it and move it to the sides. So I think preserving the posterior leaflet gets you most of what you want.
I see. Thank you. Thank you.
Dr. Mahmudov from Azerbaijan. First of all, I want to thank all speakers for excellent presentation. The benefit of revascularization, particularly surgical revascularization in patients with chronic stable ischemic cardiomyopathy, is well known. On the other hand, we also know that a group of the patient with low ejection fraction and sometimes high comorbidities carries in high perioperative risk. My question is, why don't we intentionally perform hybrid procedures of pump surgery plus PCI in low ejection fraction patients, knowing the perioperative advantage of off-pump surgery versus then on-pump surgery? Wouldn't this approach provide better perioperative outcomes and do the surgical collateralization, which is we are discussing this morning, results in better long-term outcomes? The second question is, if studies have shown that PCI offer no superiority over medical treatment in patients with a low ejection fraction, why should we consider PCI in patients with high surgical risk patients?
Great question. So I think complete revascularization is important, and the coronary anatomy in patients with ischemic cardiomyopathy is often pretty advanced, and complete revascularization by PCI is more challenging. So there certainly may be some patients where a hybrid approach is suitable. In the trials I described, they have to be amenable to PCI. I can tell you that a common reason is that the PCI is considered, that they're not randomized, is that the PCI is considered to be too high risk, either in the short term or long term. I think that we were describing one potential advantage is if you have an individual patient with a very high surgical risk. And if the surgical risk can be reduced a lot by a less complete procedure, then that may be someone. But I think it's more an individual than a class. I think for most patients, complete surgical revascularization is possible. And the patients we saw with Impella, these were patients with more advanced cardiomyopathy. And I think that if you don't view every patient as someone as very high risk, most patients have a relatively low risk for surgical revascularization. It's those with more advanced features, with very poor EF, bad RV, pulmonary hypertension, ischemic MR because of RV TR. Those are patients where something other than bypass surgery is probably something we should look at.
Thank you for the raising that important question, but that's problem. I think that topic is not new, but old, not old. The thing is, I think best beauty, the beauty of the bypass surgery is a little LED. That's every single cardiologist recognize that is, even in the future, better than PCI. That's the most beautiful part. But on the other hand, I think, do you remember this morning, the cardiologist from Emory is Dr. Pascal's partner, saying, they are really disgrace the vein graft all the time. So their stenting technology and also the new PCI device getting new every single year maybe. So that combination of these things, hybrid, it's coming every new phase, every single year. So on the other hand, we don't have clear evidence because that's a hybrid. It's a so different type of, PCI first, CABG first, or also that mixed CABG and mid-cap, different types coming with some device, robotic assisted. So I think we do need a good future registry or some evidence. Otherwise, we cannot say definite things. That's my opinion. What do you think?
I agree, and I see Sam Balke here, if he wants to say some words in the robotic and hybrid. I think there is a role, but we need to figure it out, and we need not to abuse or over-abuse this, the value of this tool. Otherwise, we will get in trouble for the value that coronary is bringing to the society.
Tim, thank you for coming.
Thank you, Gianluca. Great session, and I enjoyed Mark's talk and the talk on the Impella. I think one of the things that off-pump bypass came to do was to lower the risk of the operative intervention. And the people that we want to lower the risk of the operative intervention on are the ones with high risk, which is poor LV function. So if you can execute an operation that minimizes the risk to that ventricle, but also provides complete revascularization ideally, or incomplete surgical revascularization then completed by PCI, then I think you have, we all have these great cases that underwent an arrested heart operation with an EF of 10%. We put an Impella, we put them on ECMO, we got them through, they went home in 14 days. But if we can minimize that risk during surgery, and the minimization is by not even stopping their heart, then maybe we've done more people a favor. And then if we can prove that a Lima LAD is really what matters and PCI to the rest of it can be okay, then I think that's the conversation. This is a conversation, Dora, we've been having for a long time when we talk about OPCAP versus arrested heart. So I think that's an excellent kind of, the two sides of the coin to think about in a session on low ejection fraction coronary surgery. Is there a role for OPCAB? What are the differences between OPCAB in a normal ventricle versus OPCAB in a low ejection fraction patient? And then the role of hybrid. So I think it's very, John, I mean,
Thank you.
you've written on this. I think low ejection fraction OPCAB is a big deal.
And we let you close there, Dr. Pascas.
Actually, one of our former Emory residents, Polomsky, published an interesting paper from the STS database on low EF and the relative benefit of OPCAB over conventional CABG, and it was striking. As you might expect, those patients that do worse with conventional on-pump surgery benefit most from avoiding the heart-lung machine. The patient group that benefits least is a healthy young man. Those are the patients enrolled in the Ruby trial.
Yeah.
And that's why that trial didn't show it. There may be some other reasons, but that was, I think, the predominant reason why they didn't demonstrate benefit. But elderly, sick patients with low EF, if you can do their operation safely off pump without prolonged hypotension, then you don't ever have that problem of weaning off bypass.
Well, should we conclude the session? I think there's a lot of still remaining problem. I think that from my personal opinion, the best operation is beautiful, off-pump, multi-arterial, but look at the art study or others. It is more difficult than we think to generalize in terms of generalizability, the whole around the world, depending on experience, depending on the patient characteristics. So this discussion will certainly continue. So we conclude this session. Thank you very much.
Thank you so much.